We want to prevent diabetes and we want to prevent the complications of diabetes. What we really need to do is focus on behavioural medicine and psychology science. And to do that, I'll present some of work that's been done more widely, and there'll be some of my own work in there a little bit all the way through. So I'm not going to talk about all the roles and all the ways psychology impacts and psychosocial issues impact people with diabetes. To do that, I have 1,200 slides. And I'm not sure you want to be here that long. But I'm happy to answer questions about that at the end, one-to-one, or if there's more generic questions, I'm happy to do that. But there'll be some issues that I'll flag. So what I want to do is convince you why is psychology really important in diabetes. Now, first of all, I know diabetes is a big issue here in Singapore, but it's a big issue globally. Currently, there's 1 in 11 adults in the world with type 2 with diabetes. They're projecting that by the year 2040 globally to become 1 in 10, or 642 million people will have diabetes. So it's a big issue globally, not just in Singapore, but in Singapore we have 1 in 8 adults have diabetes in the general population. So this is from the International Diabetes Federation's Diabetes Atlas. They do this on a regular basis. This is 2015 data, so it's out of date already. So they were estimating there's about 541,000 adults with diabetes in Singapore, but there's also about another 46% of people who have diabetes who are currently undiagnosed, they're estimating. And every year there'll be about 3,800 deaths in Singapore attributable to having diabetes. Globally, we would say 1 in every 6 seconds someone dies because of the consequences of diabetes. And diabetes-related expenditure is related to be about $3,000 per adult with diabetes. So that's the situation here in Singapore. And how does that compare globally? So we might say the prevalence of diabetes in adults. So globally, we'll see here in Singapore, we have 10.5% versus it's about 8.8% in the globally, and prevalence of people with, this is IGT, or impaired glucose tolerance. So that means people are very high risk of developing diabetes. If you have impaired glucose tolerance, we would say 50% of people who have impaired glucose tolerance will develop diabetes within the next 5 years. And so we see about 14% of people in Singapore compared with just under 7% in the general population. So there are very specific issues and burdens that the population in Singapore is experiencing. So what are the risk factors for diabetes? Well, you can break this down into some well-established ones you can't really do too much about. So there is a genetic predisposition. You don't inherit type 2 diabetes, you inherit a risk for developing type 2 diabetes. Many times we explain this as like you inherit a weak link in a chain. And it's only when you put pressure on that link does it break and you develop diabetes. So you don't inherit it, you inherit the risk. And things that put pressure on that is, unfortunately, we can't do anything about age. As we get older, the risk increases. It's not something we can do anything about at the moment. And for women who've had a history of gestational diabetes, that is again a very high marker for the risk of developing diabetes. It doesn't give you diabetes. We tend to think of it as more as a marker that's telling you you are at very high risk. So if you have a genetic predisposition, the 2 things that everyone will have told you about that have an impact on your diabetes is diet and activity. So I just want to talk a little bit about that, because we can prevent diabetes if we can identify those at high risk and provide programs to them to support people at diabetes who have that to prevent it. And there's 2 ways of doing this in the literature. One is to identify people who are very high risk, so they have pre-diabetes. And the other idea is to target specific single factors, so trying to promote activity or promote a diet. Where we have the strongest evidence is in this area of pre-diabetes. Now, the really interesting thing about these studies is the goals that we're trying to achieve are not that big. So this is a summary from the 3 biggest trials that have shown we can have a huge impact. a weight reduction of 5% of total body weight. We're not even saying that you need to go from being obese to non-obese, just a 5% weight loss. So someone like myself who's a bit overweight, that's about a 5 kilogram weight loss. That's not a large amount of weight. That we want to reduce the saturated fat intake, so the amount of energy you get from animal fats. So someone was asking me before this meeting about can they still eat Wagyu beef? Yes, but you only want the fat to be about less than 10% of your total energy, saturated fat. Your total fat to be about less than 30% of energy. And you eat more fibre and physical activity, moderate physical activity, about 30 minutes a day. One of the important things to really know about these diabetes prevention trials, they have not targeted sugar intake. Sugar is not the issue. Sugar is a problem because it's a calorie, gives you energy that puts you overweight. It's actually fat is the big nasty food. That's the one that actually affects the way your body metabolizes insulin and glucose. So we haven't overtly targeted sugar. What we do, sugar is targeted as a way of reducing calories because there's lots of calories in a sugary drink. But it's fat is the really toxic element in our diets. Now this is from the Finnish Diabetes Prevention Study, where one group had nothing and the other group were given regular 3-monthly education, exercise, motivational sessions. And they were followed up, in this case, this is follow-up time in years, so this is 8 years later, and we see that the group that had no intervention increased their rate, this is their progression to diabetes. So you see, within about 8 years, about 50% have developed diabetes. As you see, this is greatly reduced in the intervention group. It's about a 57% reduction in the rate of developing diabetes for a relatively modest reduction in lifestyle. If we go to look at the really long-term follow-up, so these are the 3 big studies, the Dudging study, the Diabetes Prevention Study in Finland, and the Diabetes Prevention US study. And what we see is when we look up follow-up, so even at 20 years follow-up in the Chinese study, we see a 43% reduction in the development of diabetes. So that's half as many people developing diabetes with a relatively low-key change in their lifestyles. The Finnish study, they have about a 58%, but they've only got 7 years, 58% at 10 years in the American study. So actually making small changes has a huge impact. The trouble is these studies were done very intensive, lots of input, and what we tried to do is translate that into the real world setting. And what we find when we do that is this is 2 studies, just very quickly, you don't need to worry about the details so much, these are 2 studies done in Melbourne, one targeting particularly an older population and another one targeting women with post-gestational diabetes. Actually, we only get a very little weight loss. So if we go to our intervention group, we've only got less than a kilogram weight loss in our intervention group. And if we look at the different targets we're changing, you see very few people meeting those targets. We can see the same thing in this study as well about, this is women who've had gestational diabetes, and again, very little changes that we're seeing. In actual fact, we show a significant difference in this study, but it's not because the intervention group lost weight, it's actually because the control group put weight on. So all we were able to do was stop people gaining weight. And that's a problem because we really need to get some improvements in outcomes. So why, if these studies are showing this, why are our translation attempts to make this work in the real world not working? I think first of all is because we've actually moved from what I would class as behaviour change models. Changing behaviour takes hard work. And what these models have gone from those intervention studies where we saw regular monthly or 3-monthly contact to help with those changes. Over 3, 5, 7 years. It was long periods of intervention. Where they've now switched to a lot of these, the medical world has tried to switch to what I would class as an inoculation model, is we'll give you a dose of motivation and a dose of information, and that should sort you out for life. Unfortunately, the things that make it hard to change our life don't go away once we're inoculated. They're still there. and they're still nagging at us constantly to change. So one of the things I've noticed here about Singapore, I'm constantly being bombarded with images to eat food at all the restaurants and places, and it's always there. So being inoculated against that just doesn't work. We need this ongoing support. So these translation models haven't really done that. But I would also argue that these interventions are still largely uninformed by our behavioural science literature. And the reasons for that is these two studies, as you'll notice, I'm actually a co-author on both of them somewhere, so here we are. But I'm the only psychologist in that whole study group. The whole study is about changing people's behaviour, and most of these people are medics. There's one psychologist, one dietitian, a couple of nurses, and one psychologist. And so the intervention, no matter how much I fight for it, was not actually developed by myself. I had some input. And so just to show you an example, both these interventions are relying on a model of behaviour change called the HAPA model, which stands for the Health Action Process. I always forget what the second P stands for. We call it HAPA anyway. Now, the interesting thing to know is I was asked why should, and I said, well, we shouldn't use the HAPA model. And they said, why not? I said, well, it doesn't work. So this is data from a meta-analysis of many intervention studies to change health behaviours. And what we see is these are the names of the different theories that have been used to inform those interventions. And what you'll notice is the HAPA model is just here. So this is it's classed as these stage models, it's down here. And it's been shown to be half as effective as the most effective intervention. And yet this is one of the most commonly used models in behaviour change studies in diabetes prevention. We have motivational interviewing down here, which is one of the most popular things I get asked about. Can you teach me to do motivational interviewing? I go, no, because it doesn't work very well. Yet these are the kind of things that we're constantly being asked to do. We're not actually using the best evidence we have about what are the most effective models. Oh, and just as a note, because there's a lot of content in these slides, all the slides will be made available to JCU so they can be disseminated free of charge so anyone can get access to them. And I have no issues about copyright issues. If you want to use them yourselves or anything, just feel free. It's not a problem. It's complete free access as far as I'm concerned. So we're not using the models that we think we should be using. And also we easily get caught up in technology. This is another meta-analysis. So this is taking lots of studies, particularly targeting weight loss in women after they were pregnant, and looking at what predicts whether they are going to lose weight. And what we do is we look at all the different techniques that have been used in those studies to see what actually predicts effective weight loss. And what we found is actually one of the most important predictors is what we call self-monitoring. So actively, regularly recording what you are doing. Whatever that goal is, whether it's physical activity or whether it's eating more fruit and veg, or in my case, eating less ice cream, it's about actively monitoring that and keeping a track yourself. Now, one of the things that's happened in the world is we've got technology, and we can get technology to do that. And so, particularly in the world of physical activity, we've got lots of people using pedometers and tracking devices to see how active we are. And we've been told, well, that's because that's self-monitoring. Now, it's not self-monitoring. That's tracking. And the best example of why this is important is different is a study that was published last year by an American group. This is a weight loss study where one group were randomized to give state-of-the-art best practice weight loss. So they've got the best program we could come up with. The other group got that program, and they were given pedometers to monitor their physical activity. The problem is, so we got standard best practice weight loss, and we've got the enhanced. Now, the key thing about this study is the actual group that were using the pedometers lost less weight than the group that were using the best practice model. This group are not self-monitoring their activity, they're relying on a device to do it for them. This group are monitoring it themselves, they're actively recording their activity each day. And we see massive differences in weight change. The people that are using the tracking devices lost less weight. because they're not actively self-monitoring. Yet nearly all the weight loss programs I see are encouraging people to use pedometers to track their activity. The evidence would suggest that's not going to be beneficial. And just to bombard you with more psychobabble, this is another meta-analysis and probably the best evidence we have at the moment. This is a study where they've looked at a large number of intervention studies to help people change, change their health behaviour, so diet or exercise or alcohol. And what they've done is they've looked in detail at what the intervention person did and categorised all the different techniques we might use. Just as this is actually a short version, we've done a separate piece of work in there. We've got it down to there's 98 different techniques we might use to motivate you to try and change behaviour. In this study, they've only looked at 24 of those, but there's 94 documented ones in the evidence. Now, what they did, instead of just looking at what individual technique works, they've looked at what happens if you combine them in particular sequences. So does it matter if you combine particular strategies together? And so the key thing about this particular work has shown that there's a couple of really key combinations of things you want to do. If you want to help someone change their behaviour, there's some really simple techniques that we can use which have really strong evidence. Now, these bars here represent the number of or the percentage of studies that had a big impact on behaviour change. So they had a high success rate. So this means 30, oh, no, beg your pardon, I'm going the wrong way. Here we go. 36% of studies that didn't use prompt intention formation, and I'll explain that in a second. Only 36% of those studies who didn't use that had a good success, whereas 77% of studies had a very high success rate for behaviour change if they combined these two techniques. Provide information about health behaviour link. So instead of just telling someone exercise more, actually give them information about, well, how does exercise help? What's that actually doing to your body that's going to be beneficial? And then getting people to prompt what we call an intention formation, which basically means asking the question, when, where, and how are you going to do it? So not how do you become more active, what are you going to do? I might go for a walk for 10 minutes on a Tuesday morning, and I'll do Thursdays at 5 p.m. Getting it articulated down to how, when, and where. Just doing that activity with someone, from other studies, increases the likelihood they'll do that behaviour by about 50%. It has a huge impact. So how, when, where are they actually going to do it? Has a huge impact. So those are two strategies. These are fairly similar. Prompt specific goal setting. So specific goal setting is similar to that, but my goal is I want to eat one portion of fruit and veg a day, 4 days a week. And I want to do that for 4 weeks. So making sure it's specific and it's monitorable, but also what we class as setting graded tasks. Our total goal might be to get to 30 minutes of physical activity each day, 5 days a week. But you don't go for that straight away, because that means none of us will do it. So actually setting a task and getting there gradually, and doing that in step process. So grading how you do that. So making it slightly increase each time. And there's a good way of knowing whether someone's likely to actually be able to achieve something. We will commonly ask someone, so you want to say you want to exercise 10 minutes a day, 5 days a week for the next 4 weeks. So if I see you in 4 weeks' time, what's the likelihood that you will have achieved that? 0, there's no way it's going to happen. 10, not a problem, almost definitely. If someone says less than 7, it's not going to happen. It just isn't, don't bother. So what we say, if they say less than 7, we say, how does this need to change so you would score it more than a 7? And then you gradually increment things. So make things realistic. And two other things that turn out to be critical: prompting of self-monitoring behaviour. So setting reminders to monitor how has it gone. How did you do that activity this week? Did you recall that? Did you note that? There's some very nice, simple, cheap, non-technology tools that we use. One of the most effective is getting an empty jar and putting in Australia, I use a $1 coin, but every time someone's wanting to achieve a goal, every time they do that, they put a $1 coin in the jar. So each time they do it, they're seeing that increase, so you see the success. And then once the jar is full, or you've finished that task, you can spend the money on whatever you like, as long as it's not food or alcohol. But it's that prompting, that self-monitoring, putting those cues in your environment and prompting a review so that at the end of the 4 weeks, you actually look at what you did and decide whether that's working for you and change it or not. Those 6 simple techniques increase the likelihood that someone will change their behaviour by about 70% if they're implemented consistently. But we know they're not implemented consistently in healthcare. And we see that still largely these behaviour change programs and delivery programs are managed and implemented by non-behavioural scientists, not psychologists, sociologists, people with a mental health background. It's largely not them delivering these programs in the real world. And why is that important? So I go back to Webb and Sheeran's meta-analysis. Actually, this is the size of the effect interventions had. When we used a health educator, a trained health educator facilitator, a teacher or a clinician, the effect size are much less than when we used the research assistant. And guess what? The research assistants were psychologists. And what a surprise, the psychologists get a better outcome. But we're not learning that and thinking about how we do that in the real world. And this is just an example from our diabetes prevention study, one of the studies I just told you about earlier. We had 4 different facilitators delivering exactly the same program. And they've all seen clients for roughly the same amount of time. And this is the difference in how much time they're talking, but more specifically, time delivering the particular techniques that we want them to. And so what we see here is that facilitator A is actually delivering our intervention techniques much more frequently than our other facilitators. And then unsurprisingly, this is a change in HbA1c, so average blood sugar levels. Our facilitator who's delivering our intervention actually gets a reduction in blood sugar levels, whereas the others don't. They actually get an increase. The ones that are doing what we want them to do actually get the outcomes we want. So we know the pre-diabetes, these pre-diabetes programs work if they're delivered properly and consistently over time. But what about if we try to change behaviour in the general population, not just those at risk, the whole population? Well, unfortunately, the data is a bit depressing. This is a Cochrane review. So Cochrane is a repository of people doing very high-class meta-analyses and reviews of interventions. And this is a review of trials to promote physical activity in the general population. And of these studies, you'll see there are 4 in red, and 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 10 in red, 4 in green. The 4 in green had a beneficial impact. The ones in red, no impact whatsoever. And what you see, the most majorities are suggesting when we go to the general population interventions, they're not having much impact on physical activity. There are some other studies around diet and exercise, diet showing similar kind of things, but the data's not as well documented and robust. So why are we not having this effect on the general population? Well, again, I'd like to suggest it's because we're not using what we know about psychology and the way people think. This is just some examples I took yesterday off the web, put in health promotion campaigns, prevention diabetes, and these were some 4 other images that come up. Now, one of the things that really strikes me about many of these images is they're focused on generating fear of losing legs, of death, of complications. And actually, when we look at a lot of the literature to promote health, fear is used a lot to try and get people to change. And that would seem to make sense because theoretically, lots of the theories articulate that our motivation to do something, so this is the motivation here, should be a function of the interaction between how serious it is and how likely it is. So in theory, the more likely it is and the more serious it is, the more motivated you should be to do something about it. And this was developed by a guy called Neil Weinstein, and he calls this a motivational plane. So this is a plane of what motivation should look like. Now what Neil Weinstein did is a series of very elegant studies where he asked individuals about a whole host of health risks and asked how likely do you think this is to happen, and asked them to rate how serious that was. And then as a marker of motivation, he asked them, how much would you be willing to pay to make sure this never happens to you? So that was his marker of motivation. And so he used this to generate a series of motivational planes. And this is what each individual's motivational plane looks like. Now there's a couple of interesting things in here. One is this individual is very interesting because he doesn't look like he's motivated to do anything ever, because he just gets no motivation. So I'm not really sure. I was assuming he's an Australian surfer or something like that. But the other thing you'll notice is none of these planes look like that theoretical plane. Everyone's is different. Now what we can do is we can take that and we can try and aggregate that data to try and create an average motivational plane. And what you do is you get something that looks like this. Now some of this is very consistent. So where we think low severity, it works. So with low to moderate severity, the more serious and the more likelihood, the more motivated you are. But when you get to serious things you think are very serious and very likely, actually your motivation goes down. When you think it's really serious and it's really likely to happen to you, we see a demotivating effect on motivation. And we can see this pan out in some other work, which is, again, this is a meta-analysis analysing data across multiple studies. And what's interesting about this study is they've looked at interventions that are targeting and promoting health by focusing on threat, so making you think it's serious, it's going to happen to you, you must do something. And interventions focused on efficacy, i.e. promoting your sense of your ability to do something about it. Not so focused on how serious it is, but your ability to change. Now what we see is threat messages generally had no effect. So if we just tried to motivate with using fear, no real benefit of doing so. More importantly, when individuals have low efficacy, so they don't feel like they can make changes, trying to scare them made them worse. So think about that. I don't know, I've been, I just don't see how I can increase my activity. I can't change my diet. Oh my God, that's really, if I don't do that, I'm going to die a slow, horrible death. Doesn't really kind of feel like it's going to motivate us, and it's actually doing harm. However, when we use a threat message, when we convey a sense of efficacy, i.e. you can do something about this, it has beneficial effects. The key thing is you have to do the two together. You have to create a sense that you can do something as well as that you should do something, you need to, but how can you do something? And that has beneficial effects. But also just creating a sense and increasing a sense and focusing on people's capacity and ability to make change actually is beneficial. So I was really gratified when I also found, I'm not going to play the video, but actually this was the video campaign that I saw for Let's Beat Diabetes that was being published in Singapore earlier this year, which is really focused on helping someone focus on you can make a difference. You can do things to change it. So there are good models of it out there, but these tend to be the exception when we're looking at general health population effects. There are also some really nice tools that you can get free. This is an app produced by Bupa called the Quick Age Health Check. And it's quite nice. You just put in your age, weight, some simple measures of exercise and diet. There's some information about how you do this. The really nice thing about this app is it will give you your health age. So obviously this is not me. But what it will do is basically saying if you're 14, you've got a health age of 38, you're doing well. If you're 14, it comes up with a health age of 60, you're not doing quite so well. And it compares, so you're compared to others. The interesting thing for me, it gives you your risk of death as one of the options by a certain age, because of course your risk of death is 100%. But here it's putting for age 70. But the critical thing for me about this is if we look at the risk of death, developing diabetes or heart disease, it has this section in light blue, which is risk you can't do anything about because of your age, your family history, etc. But it gives you all this risk in dark blue you can do something about. This is changeable risk. So it's really a really nice app because you can play with some of the lifestyle factors and see how impact that does on your risk. And it's free, and there's an increasing number of tools like this out there. So focusing on giving people both the threat and the seriousness and the capability to do something about it. But there's a couple of other risk factors which we don't talk about very often. One is depression. Having a history of clinical depression increases your odds for developing diabetes by 37%, over and above all other risk factors. So it's a major risk factor for people with diabetes, for developing diabetes. It's also a risk factor for heart disease as well, but we have really good meta-analytic data that it's an increased risk. But we know treatment works. Actually, if you get treatment for depression, it works. I've put this up because it's a comparison of interventions either for pharmacotherapy or psychotherapy, drugs or people. And these are a whole series of studies that have tried to compare taking drugs versus going and seeing a therapist. And in summary, the bit is at the bottom is absolutely no benefit to either one. They both work. Absolute no difference. When you aggregate across all these trials, there's absolutely no difference between the effectiveness of seeing a therapist or getting some antidepressants. They both work. We need to get people treated for their depression. It increases your risk. The other thing about depression is we see very high rates of relapse of people with depression. And now we've actually got very good data that mindfulness-based techniques, so Western psychologists have gone and stolen a load of stuff from Buddhist psychology and recalled it mindfulness-based cognitive therapy. It could just be called meditation, but we've called it mindfulness cognitive therapy. It's actually a very good tool for preventing the relapse of depression. So if we teach people some meditation techniques and get them to do that regularly, it substantially reduces the likelihood that they'll have another episode of depression. But again, we don't do this in routine practice. And then the other one that we've now added to the problem is sleep. This is data from a fairly recent meta-analysis, and this is the relationship between average number of hours sleep and risk of developing diabetes. The main issue we find is people who have short or disturbed sleep or who sleep for a very long time have very high risk, increased risk of developing diabetes. We see optimally now about 7 to 8 hours sleep a night is about optimal for health, both cardiac disease, diabetes, obesity. If you regularly sleep a lot less or a lot more, it actually increases your risk for a number of conditions. So getting a good night's sleep might look like it's a good way to go. Unfortunately, this data has only really come out in the last few years, and we haven't got any good intervention studies to show if we improve people's sleep or make it more regular, that we get better outcomes. I can't make that statement at the moment. What I can say is that people who have particularly short or long sleep tend to have higher risk for developing diabetes. So, risk factors for diabetes are behavioural and emotional. That's what psychologists do. We study behaviour and emotions. Pharmacological interventions may help for depression, but we need to use state-of-the-art behavioural science to inform our design and implementation of interventions to prevent diabetes. Well, what about once you've got diabetes? Well, one of the biggest problems that we have is that once we've got diabetes, we might get prescribed medication, and we're not very good at taking medication. This is data from Scotland, in Dundee in Scotland, where they have the hospital, pharmacy, GP computers all talking to one another. So what they're able to do is see how much medication has been prescribed by the doctor and actually see how much individuals get from the pharmacists. And now in this study, they've described getting adherence as getting 90% of what's prescribed over a 1-year period. And what we see, patients prescribed 1 tablet once a day. So this is sulfonylurea or metformin. Patients who are prescribed 1 tablet once a day, only a third get at least 90% of what they're prescribed from the pharmacy. If they're prescribed 2 tablets, only 10%, only 1 in 10 roughly, get at least 90% of what they're prescribed. Now, it may just be they're Scottish, or it may be not. This is from the US. This is from the USA. These are individuals in what's called a HMSO, so it's a managed healthcare system. Their insurance is paid by their employers, so they have the funding to get their medication. These are patients that are started on a statin to reduce their cholesterol levels. And this is slightly different. This is the percentage of patients obtaining less than 20% of what they're prescribed. So flipping it the other way around, and it's 20% less. So within 6 months of starting on a statin, 30% of patients are getting less than 20% of what they're prescribed. So that's not taking it, that's getting it from the pharmacist. And we're up here, we've got 48 after 4 years. That's about 50% of patients are getting less than 20% of what's prescribed. This is data from Australia, slightly different way of looking at it. This is what's called a persistent curve. So this is the number of patients getting any medication. So these are patients with high blood pressure, prescribed tablets for their blood pressure. These are 3 different classes of medication. And what we see, that within about 2 months of being prescribed a hypertensive medication, 20% of patients stop getting any medication from the pharmacist. So this is a huge problem. The WHO was quoted, increasing the effectiveness of adherence interventions may have a far greater impact on the health of the population than any improvement in specific medical treatment. So the WHO is arguing if we could just get people to take the medications that work, this would have far greater impact than any new medications we could come up with. So what do we know about doing this? Well, this is a quote from this is again the Cochrane Library, a systematic review. Current methods for improving adherence for chronic health problems are mostly complex and not very effective. That was in 2002. There's been a lot of research since then, and that was updated in 2005, where Haynes said current methods for improving adherence for chronic health problems are mostly complex and not very effective. It's a bit depressing, but there's been more research, and it was updated again in 2008, where Haynes said current methods for improving adherence for chronic health problems are mostly complex and not very effective. So they decided that they'd let a bit more time go past and a bit more research be done. We're bound to find something that helps. That wasn't planned to happen. Oh. And the only change here, you'll note, Haynes is the last author now. He's got fed up and someone else is doing the work. Current methods for improving medication adherence for chronic health problems are mostly complex and not very effective. And if you do a search on some of the search engines, go to something like PubMed, which is a database of medical research, and put adherence in, you will get 100 to 200,000 hits of papers on adherence without a thought. So there's the quote from the 2014 paper. If there is a common thread to these interventions, they are complex and use frequent interactions with patients with a focus on adherence. However, these complex strategies for improving adherence with long-term medication prescriptions are not very effective despite the amount of effort and other resources they consume. There is insufficient evidence at present to conclude that newer intervention types, such as mobile text messaging, internet care, can assist in improving adherence. It's really depressing reading. This is the point I want to highlight though. Finally, it's essential that researchers stop reinventing the poorly performing wheels of adherence interventions that we have seen today. It seems that most research is performed by clinicians and others who discover adherence problems while working within the context of the management of a specific condition. Now, the reason I focus on that is these clinicians are largely biomedically orientated clinicians working in conditions care, providing clinical care, trying to address the problem. The issue is they're not really looking at the psychology literature, because here's a meta-analysis published in 2013 on cognitive-based behaviour change techniques as interventions to improve medication adherence. And what we see, we have only seen a couple of unsuccessful studies, but what we see is overall, if we've used psychology techniques, classic cognitive behaviour therapy, we improve adherence. But those interventions are not being used in the vast part of the literature. And interestingly, we know also that the bits that work we don't always use. This is another meta-analysis of studies of patient education interventions. So we bring a group of people in and we're going to give them lots of education of their diabetes, and of course they're going to be educated and do much better. Unfortunately, these studies highlighted in red, the patients came in, sat down, got the education and got worse. They did not improve as a result of coming in. And we see a great deal of variation in the outcomes of these studies. So why is that? Well, this is what's called a meta-regression. They look to see what predicted the outcomes, and what a surprise, the cognitive psychology technique of reframing was one of the best predictors of whether an intervention works. So where interventions used a psychology technique that's well known to help people reframe and rethink about how they think about their disease, it was far more effective. But we don't do this. This is a study, this is a project that I was one of the leads on. It was an education program for patients newly diagnosed with diabetes. And it's a 6-hour program designed to be for people as soon as possible after they're diagnosed. And we had some standards about how this program delivered. One of the criteria is that actually we don't want the educators to talk a lot. We actually want them to listen. So find out what people are thinking and feeling about their diabetes and use that to have a conversation. So when we set the standard about was the intervention delivered, we set some educator talk time targets. So this is the amount of time the educator is allowed to talk in the different sessions. So in the first session, the educator is only allowed to talk 40% of the time. And in these other sessions, 50% of the time. This is what, when we looked at the 14 different centres delivering the trial, this was the average talk time. And as you'll notice, for most of these averages are well above what we were trying to train them to do. So the bad news is I was trying to train people to deliver an intervention a certain way, and my training didn't work. And this is the number of out of 14 centres, this is the number of centres that actually met the targets that we set for each one of those things. The critical thing in this particular study is what we found is the less the educator spoke, the more effective the intervention was. The more they listened to people with diabetes, the more effective they were as educators. So they're not using the techniques we want them to use in group sessions. This is data we've done in one-to-one sessions. So with these series of studies now, what we've done is we pounce on a patient as they walked out of the consultation room, and we grab them and we ask, so what decisions were made in that consultation about your diabetes? What were you told you've got to do? And at the same time, we've got the healthcare professional, and we've done this with dietitians, physiotherapists, GPs, consultant endocrinologists, occupational therapists. We get roughly the same data no matter who gets to do it. Even some of our psychologists were similar in this data, so I can't go from there. So this is a summary of the data from in one of the studies we published. So what we do is we compare what the patient says with what the doctor, for instance, or the dietitian has said. So in green we have where both the patient and professional recall and agree on at least one thing that was said. So about 40% of the time a patient and a professional recall at least one thing the same. About a third of our consultations, neither the patient or the professional recall a similar thing. They recall completely different treatment decisions in 1 in 3 consultations, 30% of the time. And then we've got about 20% of the time where the professional correctly recalls, and the way we know it's correctly recalled is because we audio taped the consultation and actually checked with what they said. So about 1 in 5 consultations, the professional recalls things correctly, but the person with diabetes doesn't remember them. But interestingly, we have another small group, it's about 7 to 10%, where the patient correctly recalls what was decided, but the health professional gets it completely wrong. So this creates huge issues. If we can't get these things right, how do we expect the outcomes to be helpful? So, you know, we've got problems with doing this. And the last thing I'm going to talk about on this issue, this is a study group that I'm involved with. It's called the Hvidoere Study Group on Childhood Diabetes. It's called that because every year we meet at the same place in Hvidoere in Denmark to plan the studies. And it's a study group. It's 21 centres around 17 countries around the world, including, it's mostly Europe, but we've got North America, Canada should be on there as well, Israel, Japan, and that's in the wrong place. It should be down there. It's Melbourne. Now, one of the interesting things about this study group, this is in paediatric type 1 diabetes though, is that this study group, we've been working over 20 years now, and what we find is fantastically huge differences in the outcomes of the patients between these different centres. So this is the mean HbA1c in the different centres from the lowest centre to the highest. 2 standard deviations difference in the mean HbA1c. In my world, that is a massive difference, and the projected outcomes of patients are huge. But each centre is a centre of excellence in its own country. And when we try to explain these differences, we can't, it doesn't seem to relate to what treatment they're on, it doesn't seem to relate to family, culture, their lifestyles. We've done a huge range of different studies. And even when we tell them that this is the outcome, and then we go back 5 years later, we see very little changes in the outcomes of those centres. So I was invited to join this group and to say, well, you're the psychologist, tell us what's going on, because it's not medical, it's got to be something else. And so we did a whole swathe of questionnaires, everything that we could possibly think of. And it was very interesting, there's only one question that we asked explained any of the variability in differences. And this came about very simply because when I was working in a paediatric diabetes team, my first 3 months, all I did was follow patients around. So they'd see the dietitian, then the nurse, and then the doctor, or some the doctor. And I just follow patients around. And after 3 months, the head of the service said to me, so you've been following, you know, what have you learned from following all these patients around? I said, well, you all completely disagree with one another. And he went, no, we talk to each other. No, we don't. I said, you do. He said, no, you don't. So I said, okay, I gave out a piece of paper to all of the members in the room. So there's 8 different staff, and I just asked them some simple things. What do you tell patients should be your target HbA1c? What do you tell them should be their fasting blood sugar? And what do you tell them should be their fasting sugar 2 hours after a meal? Write that down. 8 different staff, 7 different answers. And so we asked that question in this study. And these are the percentage distributions with the team. So really, if everyone's in agreement, they should be saying 100%. So of these 21 centres, 1, 2, 3, 4, 5, only in 6 of those 21 centres did the whole team agree on one of the most important pieces of information about diabetes care. And as they say the target they want to tell patients by the team kind of gets higher, oh, what a surprise that HbA1c gets higher also. And what we found is this interaction between agreement and target was the best predictor of differences in outcomes between centres. So teams that have got more disagreement are getting poorer outcomes. Now the problem, of course, is that's type 1 paediatric diabetes, it's one small team. If you've got type 2 diabetes, there are people distributed all over the place who are not necessarily ever seeing one another providing care. So we've got this disorganised, non-communicated care. The other interesting thing about this data was collected in 2004, so we told all the paediatric diabetes teams this. We said, you don't agree with one another. Go, no, we do. We said, no, you don't, look. You don't agree with one another. And we tried to get them to work out how to find ways to coordinate and work together better. 5 years later, we surveyed them again. This is unpublished data. It's just about, and we've only now got 1, 2, 3, 4, 5 teams, 6 teams agreeing. So it's the same number of teams. These other teams still can't agree with one another on some really basic information around what they're trying to achieve with diabetes care. So there's something really, organisational psychology has a huge role to play in what's going on here. And we also have huge issues around patients aren't following treatment recommendations, but healthcare professionals aren't following treatment guidelines either. I've just put this up as an example. This is from Australia, and you can get this data from many countries around the world. So this is the patients with high, let's say, high triglyceride levels, those that are not prescribed medication, and the proportion that are, those that are and the proportion that aren't. As you can see, lots of people who should be on medications were not being prescribed medications, and some people who shouldn't are. So I'm coming towards the end, and hopefully you're still with me. So one of the interesting things for me being in Singapore, and I was really struck by this a year ago when I first visited to talk to some people about diabetes rather than just on a trip, is you have these national guidelines. Now, one of the things that's very interesting about your national guidelines, it has probably got the best statements about psychosocial care of any national guidelines anywhere in the world. So your national guidelines actually say psychosocial care is really, really important. So it says assessment of psychological and social well-being should be included as an ongoing part of diabetes management. It says we should be monitoring well-being. And it's got guidance around psychological care at diagnosis, psychological care during the maintenance of diabetes, psychological care during complications, and about facilitating community and social support. You have really good guidelines on psychosocial care. And I would argue, until the Americans released a statement in December last year, you probably had the best in the world when it comes to clear guidance on the need for psychosocial care as part of diabetes. I don't know why I keep doing that. And it's really important. Depression, again, is important once you've got diabetes. So this is we see that people with diabetes have a prevalence of depression about 1.5 to 2 times higher than the general population. So we would probably estimate in a group of patients with type 2 diabetes, between 15 to 20% are clinically depressed at any one point in time. And when you're, I don't know if you're depressed, it's really hard to be motivated to change things. It's really hard to be physically active, to be socially active, to change your diet. When you're depressed, that's really hard. So it's no great surprise that actually those people who have clinical depression are far more likely to experience complications, far more likely to die earlier than those that don't have depression and diabetes. And this is relatively recent data, a big longitudinal study from Fremantle that I'm involved with. We've been tracking people over 6 years now. And what we found is we found 3 groups of people in our population. So we've got a group of people with diabetes who are generally kind of happy most of the time. They're not really getting depressed. They're bumbling along, no real issues. We've got another group who started off a bit miserable, became clinically depressed, and then went back to being a bit miserable. We've got another group who started off clinically depressed, became miserable, and then went back to being clinically depressed. This group have just yo-yoing in and out of depression all the time. But this change of what's happening isn't related to them getting therapy or treatment, it's just going on. They're constantly at this negative mood state. And the outcomes of those populations are far, far worse, which is why we need to monitor and find those groups and offer them treatment, because just as in the general population, both psychological interventions and pharmacological interventions for depression work. People will first of all, they'll feel less depressed, which is always a good start, but we also see they will get better biomedical outcomes and better care of their diabetes. So it works. So I'm going to end up with just a little bit of a grounding in the reality, though, of I don't want you to go away thinking I'm thinking you should employ lots of psychologists, and there's a very simple reason for this. This is some work that was done, published about in 2013, where this group went through and looked at what are all the needs, care needs people with type 2 diabetes have. And so they looked at 1,000 persons with diabetes, what care do they need if we want to deliver current evidence-based guidelines? So they mapped all this out: dietary advice, home nursing, education, and then we've got psychological care, so total hours per 1,000 patients, about 3,000 hours of psychological care per 1,000 patients. So what does that equate to in terms of staff numbers? So they're arguing that you need about 1.98, so let's call that 2, it's easy. But let's say 1.98 psychologists per 1,000 patients to deliver current evidence-based guidelines for the management of diabetes. Now the reality is, if you've got 500,000 people with diabetes, as you have in Singapore, That means you'd need 990 psychologists. Now, I'm not sure you ever want to have 999 psychologists in one place. It's not, you know, all we do is talk about people being depressed all the time, and it's very depressing. But this is just not going to happen. Psychologists that are trained and skilled and competent to do this kind of work, it's a 5 to 6 year training program. They don't and it's a long program, and they don't materialise. We're not going to get 1,000 psychologists to do all this work. So what we actually need to do is actually use research to work out how we can take this psychological understanding and knowledge and equip the health workforce we have with those skills. That's what we need to do, because we can't get 1,000 psychologists. So diabetes prevention and diabetes care needs to be informed by psychological science if it's to prevent and be managed effectively. My argument is it currently is not. Now, if you want any more information about any of this, or you want copies of slides, either contact JCU or feel free to email me. I'm happy to share any information, papers or anything. Just feel free to email me. Happy to share as much as you like. Thank you very much.